Thank you. That was an extremely generous introduction, and I think became more and more embarrassing throughout the presentation. Let's see if I can figure it out. Okay. So I wanted to present a topic today that is really going to elevate above our typical basic science and clinical scientific presentations. In part, Thanksgiving is tomorrow, we're all in a good mood. We want this to be a fun presentation. Also, I wanted to refresh brain cells that you probably haven't used since college or medical school maybe. And something that really spoke to me in college during my time at NYU, particularly in my medical anthropology class, was that the duality of the doctor as both a scientist and a humanist is really unique, and one of the things that makes our job one of the best jobs in the world. So today I'm going to focus on the humanity of being a doctor. And the reason why you should care about this, not just because it's nice to focus on both the art as well as the science of doctoring, but because this will affect you someday, if it hasn't already, and I'm sure it has, perhaps you haven't realized it. Anthropological and cultural issues affect all doctors, regardless of your specialty, and like I said, will affect you at some point, especially given that we have increasingly global society. Objectives today are that you're going to learn what is medical anthropology, recognize that surgeons have their own type of cultural biases and limitations, and then appreciate the cultural clash, so to speak, that can affect patients' care. So the lecture will be divided into 4 segments: medical anthropology, the idea that surgeons have culture, what happens when doctors and patients collide, and lastly, the solution. So we'll start with a case presentation to illustrate. A 55-year-old male comes into your office seeking information about bariatric surgery. He's looked through the internet, spoken to his friends, talked to his internist, and after really doing some diligent research, thinks he wants a lap band. Now, you've actually shifted your practice away from doing lap bands at this point and have favored more doing gastric sleeves. And you explain to him that there's improved weight loss, better metabolic effects, as well as technical issues that accompany the lap band. Now, unfortunately, and very frustratingly, despite your charts, statistics, explanations, the patient still wants a lap band. And you can't figure it out because he's otherwise fairly intelligent, educated, well-informed man. So what gives? Now, the answer here actually lies in the cultural framework that this patient has been socialized in, and this is where medical anthropology comes in. So what is medical anthropology? Now, to understand medical anthropology, you first have to understand what is anthropology. Anthropology is the study of humankind, both past and present. And in the early 20th century, Franz Boas divided the American system of anthropology into 4 fields. The first of which is physical or biological anthropology, and this studies evolution and the physical component of our species. How did we evolve from apes and early beings to early humans, and then so forth? And then also, what are the even racial differences between our skeletal structures? Forensic anthropology comes into play, and then perhaps even being able to operate on a gorilla might be affected by biological anthropology. Archaeology is the use of artifacts and relics from the past to make inferences about those past cultures. Linguistic anthropology deals with how language is the medium through which ideas and the beliefs of the culture are relayed. And it also goes into play of what are the social organizations and relationships. These are all demonstrated by language and the structure of language. Finally, cultural anthropology, which is our main topic here, studies the richness and diversity of human customs and behaviors. And it really seeks to find what are the historical, political, religious and environmental causes that have generated those specific idiosyncratic cultural behaviors. Medical anthropology is a branch of cultural anthropology and deals with what are the cultural and societal influences on a patient's experience of illness and healthcare. Early cultural anthropology was pretty limited in view and very ethnocentristic. And the idea of ethnocentrism is that, so we think that our culture is the right culture. We wear the right clothes, we eat the right food, we speak the right way, and that's because you've been socialized to think that everything we're doing is normal. And you think that other people are doing crazy things. What are kids wearing these days? What about this tribe and wherever they are, Aboriginal, Australia or something? It's so bizarre and absurd. Later, in the 20s and 40s, cultural relativism came about, and that was no longer an idea that this other culture is wrong. Rather, you go to study what are the historical, political, environmental, religious factors that have made these people develop into what they do. Why were their customs adaptive to this environment? And the idea is that any human being put in that circumstance would have developed the exact same culture as these people did. So it's all relative. For example, this hot dog looks probably pretty disgusting to most of us, but other people might think it looks delicious depending on what your culture is. Later, postmodernism in anthropology was influenced in the 1960s and 70s by the greater postmodern movement in America and Europe. And this dashing fellow, who looks sort of similar to somebody in this room, is Michel Foucault, who was one of the main figures of the time and is credited for new ideas on knowledge, discourse, and power. During this time, the idea of subjectivity came about. So our anthropologist who's studying a culture, the ethnographer, that person is not just a pure scientist because, say, my own cultural biases and experiences really affect my interpretation of others. So my view is subjective, it's not scientific. So similar to the idea of us having financial disclosure in medicine, I could say I have a cultural disclosure in that I grew up in X, Y, and Z environment, and so my interpretation of others is marked by that. The final kind of evolution of anthropology, and this is getting towards the end of the heavy-duty theory, is out of postmodernism and the idea of subjectivity, this idea of epistemology, or the branch of philosophy for how we understand what knowledge is actually truth, became really important. And this gave rise to this last and kind of most practical academic concept, that of the other. And the other is another individual or another culture. And the point of them is that as an anthropologist, I study the other and I see how different they are from myself. And because I have cultural relativism and subjectivity, I'm able to make all these high-powered associations about them. But the last thing is that the characteristics that they have, I'm able to reflect back upon myself and say, why do I not do these things? What does that say about my culture? And so you have a foil or somebody to compare yourself against. So that's kind of Anthropology 101. You can take your first college credit. Now is where I'm going to start to try and convince you that surgeons, us crude surgeons, actually have culture. And we're going to come first back to that last concept I was just talking about, otherness. And again, just to hammer it home, the idea of the other is that it gives you a foil to compare yourself off of. So in essence, I define myself in part by what I am not. And a classic example of this in college anthropology is religion. And there's many religions that have factioned themselves off into different groups based on their beliefs. And this picture here is of some Mennonite women, and They come from a greater group of Anabaptist Christians who broke into Amish and Mennonites and Quakers, and to us they probably all look the same, but within each of those groups they think that they're heathens because this person's using buttons and this one is driving a car. And with those differences in behavior, they help define that person is an other, they're not me. So that unifies my own culture because I can distinguish a definition. All right, so let's get back to medicine. You can use this otherness dichotomy to help understand the relationship between patients and doctors. Patient is sick. The doctor is well. A patient is weak. The doctor is strong. The doctor has been through a ton of education, 4 years of medical school, residency, fellowship, and the patient is really uninformed, or maybe they're getting information from unreliable sites. And essentially, the doctor knows the truth and has science on their side, whereas the patient doesn't know the truth, has irrational beliefs and culture on their side. So this is a very crude sketch and is very kind of ethnocentrist and makes us look pretty pompous if we actually think these things. But since we feel that science is on our side and we're right anyway, then what does it matter? Who cares? We're right? The patient is wrong, we're right. But this section is dedicated to surgeons have culture. And if a surgeon has a culture, then by definition cannot be completely scientific. So let's play devil's advocate for a second and say, okay, surgeons have cultures, they're not perfect. What evidence do we have of such a thing? One text that's helpful and has been used by many introductory anthropologic courses is the study of the Nacirema. And this is an exotic group of people with really fascinating, kind of absurd beliefs. They think that the body is ugly and are constantly striving to change it. They're obsessed with the mouth and constantly seeing specialists to fix the mouth. They undergo invasive, harmful treatments for ailments at this bizarre temple called a Letipso that may not even help them. This is one passage that I'm going to read to you from an ethnographer named Horace Mann, who studied the group in 1956. The supplicant entering the temple is first stripped of all of his or her clothes. In everyday life, the Nacirema avoids exposure to the body and its natural functions. Bathing and excretory acts are performed only in the secrecy of the household shrine, where they are ritualized as part of the body rites. Psychological shock results from the fact that the body secrecy is suddenly lost upon entry into the Letipso. A man whose own wife has never even seen him in an excretory act suddenly finds himself naked and assisted by Vestal maidens while he performs his natural functions into a sacred vessel. This sort of ceremonial treatment is necessitated by the fact that the excreta are used by a diviner to ascertain the course and nature of the client's sickness. The medicine men come to their clients and jab magically treated needles into their flesh. The fact that these treatments may not cure and may even kill the neophyte in no way decreases the people's faith in the medicine men. So this is kind of a cute and funny satire, obviously, of American culture, and is not actually a real ethnography. And it's an exercise to allow students to start seeing yourself and your culture as this sort of bizarre thing composed of idiosyncratic behaviors that maybe you wouldn't have realized unless you had looked at yourself from the point of view of the other. There's many, many other pieces of literature that also analyze doctors and, in particular, surgeons' behaviors. The surgeon is often compared to traditional healers because a lot of the behaviors that we do are actually pretty similar to traditional healers. And this is completely despite the fact that we think that we're fully scientific beings. And as Dr. Coakley described a couple weeks ago, a lot of what we do is actually based in a lot of tradition and you could say ritual. So some of the similarities here you can see between the neurosurgeon on the bottom and the medicine man in the top corner are that each individual has a special garb that they wear. They both have funny headdresses. They have this interesting cleaning ritual where they stand in front of a sink and scrub for 30 seconds on this side and then that side for a total of 3 minutes. They do their work within a special sacred space that only certain people can enter, and have a particular set of special instruments. In fact, the more important surgeons may have even special instruments that only belong to them. Just really, this is important. And then lastly, I would even suggest that we use the placebo effect, even if we might not be willing to admit that. It's been well documented in orthopedic literature that arthroscopy and sham placebo procedures often result in similar levels of pain relief. And I wonder if perhaps some of the results of elective lysis of adhesions and robin egg blue cholecystectomies might have similar types of placebo healing. This isn't necessarily a bad thing. Now, am I saying that you're a shaman? No. But I want you to understand that there's more to your craft of what you do than being a completely scientific body. And I know that nobody in this room would contend that, but that's the essence of what I mean when I say that surgeons have culture. So like we said before, it follows that because we have culture, that the type of medicine we practice is contaminated by that culture. It's not completely scientific. So now that we know what medical anthropology is, and secondly, accept that surgeons have culture, what happens when our culture conflicts with the culture of other patients? So first of all, what is our culture? And the name that our culture has been given by anthropology is called Western biomedicine, and has derived much of its principles off of scientific theories and evidence-based medicine, and is also called allopathic medicine. That's another term that you might see. And it's in direct contrast. These are now the others: Ayurvedic medicine, Chinese traditional medicine with the picture of cupping or coining here, acupuncture, homeopathic medicine, chiropractic medicine. So now that we know that Western biomedicine is our culture, again, what happens when Western biomedicine clashes with another culture? A classic book that I hope you've read, or if you haven't read, we'll look into reading, explains the deep conflict between one patient's family and her doctors. And this book is taught in medical school and anthropology classes, and really is a wonderful read and is very accessible. It's the story of a young Hmong girl named Leah Lee who has seizure disorder. And the doctors that treated her, naturally being raised in Western biomedicine, thought that she had epilepsy and wanted to give her strong medications and hospitalize her and do invasive procedures, and felt that all the risks and side effects of doing these treatments were warranted because of the greater benefit of treating her seizure disorder. So seizures are bad, we have to treat it, and any side effects are acceptable. Now, the doctors actually had a very difficult time controlling her seizures, and mostly because the family was non-compliant. Even more than not liking the side effects of the medications, the family had a completely different view of what the patient's disease was. And actually, the Hmong culture recognizes a phenomenon that's called Cao de Pei, which is the spirit catches you and you fall down, which essentially is during early life, a child's soul is not strongly tethered to their body, and if something inauspicious happens, an evil spirit can come and capture your soul, and that capturing causes the person to fall down. So completely different etiology of the process. The other aspect is, whereas the Western doctors think that it's completely bad, the Hmong have a little bit more ambivalence about the condition, and think that while they don't want her falling down, on the other hand, and other cultures believe this as well, that the shaking that the girl exhibited could be a sign that perhaps she was having a transcendental experience with the spirit world and was actually going to become a noble shaman, which is actually a very high calling in the culture, and they wanted to encourage this. So you can see, just crudely sketching out the points, completely opposite take on what the culture, what the two different cultures ascribed her disease to be due to. Unfortunately, as you may guess, the patient had a very tragic outcome, and which I won't go through the whole thing because, again, I really hope that you actually go out and read this book. Towards the end of the book, Anne Fadiman, who's the author, goes through different ways that maybe the doctors and the patient's family could have communicated better, and how could we have avoided such a terrible outcome, and cited the work of Arthur Kleinman, who is a contemporary anthropologist who teaches at Harvard Medical School. And he's developed a tool with 8 questions that you can use to ask the patient or the family to help close that gap of information, to help reconcile the cultural differences. And I'm not going to go through all of them, but just go through the first few to kind of give you a flavor of how the tool can help, because it looks kind of silly at the outset, but once you realize how different the answers are, it really can be eye-opening. So first, what do you call the problem? Now, Western doctors would say it's called epilepsy, but the Hmong would say it's called cow de pay. What do you think has caused the problem? We think it's some kind of neurological misfiring, usually triggered by an infection or some other imbalance, whereas the Hmong think that it's because an evil spirit stole the soul of this patient. And why do you think it started when it did? Well, the Hmong family has a very good answer. They say, well, when our older daughter slammed the door, it scared the soul away, and that made it vulnerable for the spirit to steal. This sounds totally crazy to us in our ethnocentric viewpoint of our way is the only way. And I'm not saying that they're right, but what I am saying is that just as crazy as their understanding sounds to us, our understanding sounds to them. So why would the parents listen to the doctors who are giving their child these poisonous medications, listen to them when they don't even think that's the cause of the problem? So you can see how the family just never met in the middle. And if you can't understand that the family strongly believes, just as much as you believe this is caused by epilepsy, that they think it's caused by the spirit catching the soul, then you don't understand medical anthropology. And this is the main takeaway point that I want you to have. Now, aside from just this kind of isolated story of this interesting immigrant child, there's a lot of literature now that goes through disparity and cultural differences and how that affects healthcare. Few of these articles actually deal with the discrepancy in what the patients and what the doctors believe, and even less get to the bottom of what those patients' beliefs actually are. And it really goes to show how little is understood in the topic. So again, patients versus doctors, differing beliefs in healthcare and how they want their illnesses to be treated. Some commonly recurring examples that come up oftentimes in the surgical literature are the idea of arthritis, where it comes from, whether or not knee replacement is appropriate. Transplant literature has a lot of information about organ donation, and oncology, both in the screening and preventative as well as the treatment side. And again, there are reasons, you have to remember your cultural relativism, why patients think what they think. And it's not just that they're uneducated, it's not just that they're crazy, they've been socialized in a certain construct to have the beliefs that they have. Let's take another example, this time a little bit closer to home, not an exotic immigrant child, but a subsection of our own American culture. Let's take the case of Mr. Thomas, who is a retired bus driver. He's healthy and used to smoke, And on just regular checkup and an x-ray, because of his smoking history, was referred to for evaluation of a lung nodule. The biopsy showed non-small cell lung cancer, and imaging didn't seem to show any metastatic disease. So you recommend a resection. The patient and the wife are extremely nervous and are looking down at the floor, wringing their hands. They don't want to go through with surgery, and you can't figure out initially why. And then finally you get out of them that the reason why they don't want surgery is because many of their friends told them that lung cancer spreads when it's exposed to air during surgery. And this patient had a friend die of lung cancer 6 months ago. So we're saying, what the heck? Lung cancer exposed to air causes it to spread? That's totally crazy. It makes no sense. However, if you go back into history, you can kind of understand the situational and, again, cultural relativistic reasons why this group of people thinks this. Clearly, we can all agree that lung cancer is deadly, and only really in recent years has been something that's treatable. In the 1930s, with the first pneumonectomies, there was a high rate of mortality from the surgery itself. Later, in the 40s, even though technical ability for lung surgery got better, there was still a high rate of open-close surgery because the staging was inadequate, and so patients underwent a workup, went to surgery in hopes of curing their disease. However, during opening the chest and exposing the cancer to air, and then closing because there's nothing to do, the patient then died, and the family thinks that it was the surgery that killed them, not the lung disease. And this belief really persisted despite the fact that lung cancer treatment has improved. And part of that is because some of these subsections of population are less educated and more isolated and potentially more rural populations. And so just to hammer home that point, just as much as the Western biomedical doctors think that disease progression leads to death, the patient and the family and that culture thinks that it's the exposure of air that causes the patient to die. So there's no way your patient is going to accept going to surgery unless you kind of get past that gap, and you're going to see the patient as non-compliant, whereas really you're just working through two different frameworks. So we can revisit those 8 questions of Arthur Kleinman and take the 8th one in particular is helpful for this case. What do you fear most about the sickness? We would say fear of disease progression if we don't operate. And they would say fear progression if you operate. So those are totally against each other. And if you don't kind of recognize that and open up a discourse about it, you're never going to get anywhere with your patient. So let's go back to our original case presentation. Knowing what you know now about cultural relativism, being able to examine your own American culture, and having a sense of subjectivity, why would this patient, despite scientific evidence, being very educated, why would they choose the wrong thing? Why would they choose a lap band? And I'm going to test you guys now. What are some reasons why this patient wants to choose a lap band? What are some particularities about our American culture? Dr. Salke, did you want to say something? Okay. I don't know what the connection between that and lap bands is.
It's reversible.
What's that?
It's reversible.
Yeah, the reversibility, absolutely. That is such an appealing concept in American medicine. Oh, it's quick, 1, 2, 3. I can be a little bit not sure about it and say I want to get it out if I don't think I like it. What else? There's other things. Yeah, so he got information from his friend, and I think that especially in our culture, having referrals from people that you trust is something really important to navigate the confusing medical environment. What other reasons might he have selected a band? Looks good on the commercial, but that any bariatric surgery could have done that.
He chose a surgeon who also has a lap band.
There you go. So personal preference of the surgeon, absolutely. And you guys are definitely getting getting most of this. So internet-driven information. The lap band, it's a piece of technology. We always think that, at least Americans think that a piece of new technology must be better and must be offering the best possible treatment, regardless of what the actual outcomes are, just because that's kind of the American dream and the American promise of innovation. This new thing is going to make your life better. Another thing that, so Dr. Harrington, you talked about the quick fix that's reversible, and Mike, you talked about the word of mouth. Now, the last piece, the adjustable side of it, I think is really important and plays into the fact that Americans really kind of want their cake and want to eat it too. They want to have everything. And I think especially with the oncoming holiday, we understand why you might want an adjustable band, because there's no way to be a stuffed turkey on Thanksgiving if you can't loosen up your lap band because you've got a sleeve instead. So there's a lot of reasons why he chose it, and he doesn't seem like a crazy, dumb person. It's just that this is the culture that he's been exposed to and socialized in, and that's different from our Western biomedical medical school culture. So what's the solution? Now that we know what medical anthropology is and we have some cool tools and theories to help us navigate the information, and we agree that surgeons have culture and therefore are not these infallible arbiters of healthcare because they're imperfect scientists, and we understand why patients disagree with our potentially imperfect science because their culture is in opposition to our Western biomedicine, what is the solution? So the first thing is to recognize that there's a problem, and I'm going to guess that maybe there's a few of you today that this isn't even on your radar. You're just thinking about, what are the indications for surgery? How can I better treat my patient? How can I be a better technical surgeon? But you're not even maybe realizing that this is something that's affecting your practice. And I think that a lot of the recognition of this really developed in the early 90s, where we realized that a lot of the growth of the US population throughout, obviously, the history of the US is coming from immigrants and their children and people with very obviously different cultural beliefs from ours. And this began to be reflected in textbooks and things that we were reading about. And one of the first of these is the 1992 edition of Merck Manual, which dedicates 3 whole pages out of 3,000 to cross-cultural issues. Graduate medical education soon followed. In 1995, the first psychiatric training program requirements began to require assessment of cultural influences on patients' problems. Soon after, family physicians caught on and had a recommended core curriculum guideline for culturally sensitive and competent healthcare as part of their residency. From the 2000s or so till now, really most medical schools have caught on with this and have some kind of curriculum on cross-cultural issues. And probably because, and unsurprisingly, surgery is one of the last fields to engage. And I think that this is probably because we feel that we treat really physical ailments with an anatomic cause and a mechanical problem and feel that the patient's culture has really nothing to do with that. However, as we're talking about, in order to get your patients to get on board with your treatment method, you really need to engage these issues. And the ACGME even has our core competencies, and a lot of these are reflected in cultural issues, so patient care, professionalism, and interpersonal and communication skills. And all of this goes to the point that a good surgeon, as you know, is not just a technician. They're a healer too, traditional healer. Different residency programs across the country have employed different methods to try and teach cross-cultural issues. One of these is this OSCE exam, which is objectively structured clinical examination, usually a standardized patient, and the examinee have about 10 minutes or so together, and you go through this exercise and see how well you're doing. Online modules have also been developed. However, I think there's been some backlash to those. We don't have anything like that here because it's seen as this mandatory, yet another piece of paperwork that has to be done. I think probably the most the House staff would not want to have to do online modules. Lectures, perhaps such as this one, have been given more frequently. And also, I'd say that the most important cause for residency programs to have more of this information is role modeling. So much of what we learn is from our mentors, whether they're the senior residents that we look up to or the attending physicians. What we see you do is what we're going to do in the future. So common sense would say you need to have sort of a broad approach here. And if you can't see that your own culture has its own set of interests, emotions, and biases, how can you successfully deal with somebody else's culture? And again, to be a doctor or a surgeon, yes, you're curing the disease, but a healer or somebody who encompasses the entire patient and makes that patient want to keep coming back to you and follow up and be compliant is the person who's treating the illness. So get rid of the term compliance. That implies coercion, your way or the highway. They have to do what you say. Rather, it should be more of a model of mediation, and in some areas where you can have some give and take, you need to open up the lines of communication there. Some examples of this, going back to our Hmong girl, Leah Lee, our suggestions given by Arthur Kleinman are that female doctors are best suited for female patients. Obviously, speaking to the patient in their own language is helpful. They spoke Hmong and are unable to communicate with the English-speaking doctors. Something that we see a lot of here is this issue of consent. And consent for invasive procedures can be better understood and better accepted when you enlist the support of family members and community leaders. And I think we see a lot of this in our Hispanic communities and our Hasidic Jewish populations, where they want the rabbi to say, yes, it's okay for you to have your appendix come out. And then allowing friends and relatives to be present to help navigate kind of the scary hospital situation. The Hmong really respond well to these shamanic rituals and want their shaman to be present in the hospital. And then another important factor for this particular group of patients, and I argue many others as well, is not to undercut the father's authority. And I think that we have a strong kind of emotional reaction to that. And the idea is that you really can't light your own personal or political agenda against, say, paternalism to affect your way of treating the family. If the family really relies on the father to make the decisions, you have to work, at least to some degree, within that framework. Other examples from The Spirit Catches You, which I liked because they're both from New York doctors, is one of a pediatrician, Luis Estevez, in the Bronx, who refers his Puerto Rican and Dominican patients to a Santeria high priest, in addition to using traditional Western biomedicine. And then at our own Elmhurst Hospital Center, Yasmin Collado had once allowed a medical curandero, who is a folk healer, to perform this cleansing ceremony inside the psychiatric ward to help sanctify the medications. And that led the patient to agree, okay, maybe it's safe to take these medications. Maybe I'll be more compliant now because I used my own culture to legitimize them. And at Mount Sinai, what are we doing? We do an OSCE exam in the beginning of intern year. We go to a global health program rotation in the Dominican Republic, where we get a completely different view of healthcare and what it means for the patients. And then finally, we have an extremely rich patient diversity, not only at Elmhurst, where we see probably every ethnicity under the sun, but also here at Mount Sinai, where we've said so many times before, we're at the crossroads of one of the most wealthy, privileged populations, as well as other less privileged Hispanic, Black, and Hasidic communities that have very different takes on how they want their healthcare to be run. So some take-home points. Patients have valid reasons for their beliefs. What I mean by this is cultural relativism. When you take the historic and situational effects of their socialization, you understand that their beliefs aren't crazy. They have them for a reason. And doctors cannot fully treat their patients without understanding what these barriers are. The first step is to identify them, and then after that, start engaging with your patient. And lastly, regardless of your practice, what you do, what your specialty is, you will see this to some degree. And I'd like to close by saying that you shouldn't ask what disease this person has, but rather, what type of person has the disease and how is that going to affect how I treat them? From William Osler. Thank you. Dr. Marin.